Hello. Hello, good morning, everyone. Can you hear me? I think we are still waiting for all the participants to come. Now it's almost 10 o'clock.
Good morning, sir.
Hi, good morning.
Sir, I'll start the program.
Okay.
Knowledge is having right answer. Knowledge is having right answer, but intelligence is asking the right question. Hello and good morning, everyone. Welcome to yet another session of Grey Medicos. I am Sushil Dakal, host for the event today. We, enthusiastic medical students from different medical colleges all over Nepal, came up with the platform, the Grey Medicos, to conduct interactive teacher-student session and strengthen our clinical knowledge. Gray is the color that lies between black and white. We medical students lie in the transition of knowing nothing to knowing something. Before starting today's program, I would like to highlight certain rules. Everyone must come up with their real name. Fake ID will be removed instantly. Chat box will be disabled. We will have question answer discussion session at last. You can send your query to our technical team. Let me highlight today's topic. It's hemorrhagic stroke. Without further ado, I would like to welcome mentor for today's program, a humble, energetic, and inspiring personality, loved by all of his students. Neurosurgeon of Universal College of Medical Sciences, Dr. Rajkumar Keshi sir. Sir, we feel blessed to have you as our mentor in today's program. I would also like to welcome presenter of today's program, Dr. Prakash Regmidai. He is competent, elegant, and loving person. He is third-year resident at Department of Surgery in Universal College of Medical Sciences. Thank you, Dai. I would like to give this virtual platform to Dr. Prakash Regmidai and kindly start the program. Thank you, Prakash Dai. This virtual platform is all yours.
Prakash.
So good morning to all of you. Good morning, respected sir. Good morning to all of you. Good morning, respected sir. So thank you for giving such a nice introduction. And today we are going to discuss a case. So this is a case of hemorrhagic stroke. So with the permission of our respected sir, I would like to start this case presentation. Can I start, sir?
Yeah, go ahead.
So I hope everyone is audible to me.
Prakash, make yourself a little louder and clearer, okay? Your sound is not so clear.
Okay, sir. So now, is it audible now?
Yeah.
Can you hear?
Loud and clear.
Okay. Okay, yes. So can I start now?
Okay.
Okay, this is a case of 45 years old gentleman who is farmer and Hindu and from Sanamena 8, Rukundahi. He presented to the emergency department with the chief complaint of sudden onset of loss of consciousness for 1 day and weakness of right half of the body for 1 day. So in the history of present illness, according to patient informant, patient was apparently well 1 day back. Then he developed sudden onset of loss of consciousness. And according to patient party, he was found in the unconscious state in his bed and had consumed alcohol before going to bed. And it was followed by weakness of right half of the body. So his mouth, according to patient party, again, this detail was given by the patient party. His mouth was deviated to the right side, and on being called by the patient party, he could open his eyes, and however, he was unable to give response, and he was not able to speak. So there was no history of, history of vomiting. It was one in episode, one episode vomiting, and there was urinary incontinence was present, and there was no history of headache, abnormal body movement, or history of trauma. So everyone is clear after this. I hope everyone can hear me. So in the past history, so he had no history of similar illness in the past, and he is not a known case of hypertension or diabetes mellitus or tuberculosis, or he had not undergone any surgical intervention in the past, and there is no history of bleeding disorder, any bleeding coagulopathy in the past. So in the personal history, the most significant personal history is he consumes alcohol almost on a daily basis, and he consumes approximately 250 ml of alcohol per day, which is homemade alcohol, so which can be a risk factor for in this case. So family history in this case is not that significant to us in the socioeconomic history. So this is also not that important. So I hope you can see the screen. So in the drug and case of allergic history to that. So coming to the general physical examination of the patient,
Okay.
was in the
Prakash, just wait.
okay, yes, sir.
Now, before going to the examination, general examination and specific examination, okay, just summarize the history. You need a very key point here.
Right. Okay,
we
sir.
need to discuss, okay?
So this 45 years old gentleman who consumes alcohol on a daily basis, he was found in the unconscious state by the patient party and was unable to move his right half of the body and was unable to speak for a day before the presentation to the emergency department. So he's so this is what we can
What are
find
the
from
key points? You see, just focus on the history, okay? So to everyone, so
Okay.
this 45 years old gentleman, he had sudden onset of
loss of consciousness.
loss of
And what's
consciousness, plus there is a weakness of the
right half of the body.
right side, okay? So sudden
Yes.
onset, weakness,
Sudden, yeah.
okay? So, and he had, what
So
are
he was
other problems?
So he was unable to speak, and there was a history of one episode of vomiting, along with there
Okay,
was a history of urinary incontinence.
okay. So patient was unconscious. He had a right-sided weakness, okay? He had
Yes,
vomiting, right? These are the key
yes, sir.
points in the history.
History.
And what are other positive finding in the history?
Other positive finding are the patient consume alcohol daily.
Okay.
He
So he's
consumes alcohol on a daily
alcoholic, chronic
basis.
alcoholic. Okay. What else?
So beside alcoholic, so he does not have any other significant history in the past.
So what comes in your mind, when you have such a history?
So with this
What are
history,
you
we
thinking
can
of?
So we can think, firstly, we can think about the cerebrovascular accident, CVA. So it
Yes.
can
So
be
sudden onset of any neurological deficit, you think of any
CVA.
cerebrovascular accident like a stroke. Okay. So
Okay,
this is
yes, sir.
nothing but a stroke.
Yes, sir.
Okay. And it could be hemorrhagic or ischemic, you don't know. Okay. But
So with the, yes, sir.
from this
So with the
history, you
history,
can say
we can,
that
yes, sir.
patient has a stroke. Okay. Sudden onset of neurological deficit. That is
Yes, sir.
weakness of the right side of body. Okay.
Yes,
So
sir.
that is the weakness. So you can say that it's a stroke. It's a clean case of a stroke. So when
And
you
this,
while taking a history, in chief complaint and just asking history in the history of present illness, you just make up mind. So this patient must have a stroke. So you think of the relevant history, in a stroke, what you are going to ask. So there are
yes, sir.
certain factors of a stroke that you should ask in the history. So what are those?
So history of any focal deficits should be asked,
Yes.
like weakness, like unable to speak.
That you have, okay,
And
that already you have said, okay. What
so
else?
beside that, since there can be ischemia, there can be hemorrhage in the stroke. So any features of raised ICP should also be asked, like
Okay,
vomiting.
what are those features of raised ICP?
Raised ICP could be a vomiting, headache,
Okay.
and decreased level of consciousness as this
Okay.
patient already
So
had.
that is also there in this patient. Okay.
Yes,
Patient is unconscious. He had vomiting. Okay.
yes,
So
sir.
you can say this patient has raised ICP also, right?
Yes, yes, sir. From the history we can make out.
Then what else? You have said that patient has a facial deviation. Okay.
Yes, sir. So
So
facial
what
nerve,
does that mean? What does that mean?
that means the facial nerve is also involved.
Okay.
So there is facial nerve palsy is there.
So in cranial nerves, facial nerve is involved in this case. Okay.
Yes.
Number one, there is weakness of the right side of body.
Yes, sir.
Okay. And there is a features of raised ICV in terms of loss of consciousness and vomiting. Okay. So these you just assemble these points. Okay. Now you ask for the risk factors of this stroke. Okay. What are the usual risk factors of stroke?
So for the stroke, the usual risk factor can be one of the risk factors is age itself is a risk factor.
Sorry.
So in this case, age itself is a risk factor for stroke. So old age.
What else? Important risk factors.
So other risk factor could be smoker, the patient's
Okay. Smoking. Okay. So smoking.
smoking.
Is he a smoker?
So but he is not a smoker in this case.
Okay. What else?
So other can be the patient consumes alcohol on daily basis.
Okay. Alcohol is one of the risk factor for stroke. Okay.
Stroke, yes.
It has been seen that
Yes.
strong association with alcohol, because usually in the young patient, young stroke. Okay.
Yes,
What
sir.
else? And he is an alcoholic. Okay. That is one positive point. What else?
Yes, sir. So other can be about
Hypertension. Is he hypertensive?
he's not a non-case of hypertension, but so diabetes can be other risk factor.
Okay.
Diabetes,
Diabetes,
hypertension.
hypertension. Okay. All the risk factors. Hypertension also again the risk factor for stroke. Okay. So all the risk factors of atherosclerosis are the risk factor for stroke. So these are the things you should ask in the history. Okay.
Yes, sir.
So somehow in the history, it is clear that it is a
Stroke.
stroke.
Yes.
Because why? Because it's of sudden onset
Sudden onset, progressive, and
and
with
there is the
the
neurological deficit. Okay.
deficit is present.
In
Yes.
terms of weakness. Okay. Now go ahead. In the general examination, what are the examination findings?
So in general examination, the patient was ill-looking and was not oriented to time, place, and person.
Yeah.
And then so this is not that significant in the case as the patient was not pale. There's no signs. There's no icterus, no lymphadenopathy, sinuses, clubbing, and edema was not present, and there was no signs of dehydration. So in these vitals, the blood pressure is very important in this case, because you can see the blood pressure is 160 by 110 millimeter of mercury on the right brachial artery in the supine position. So his pulse rate was 74 beats per minute, and it was regular in rhythm and normal volume with no radiolateral delay. So in the respiratory rate, his respiratory rate was 20 cycle per minute, and he was off febrile, and his saturation was 97% without oxygen in the room air. So in this case, BP is quite high in this case. So in the systemic examination, we can start from the systemic CNS examination. So starting with the higher mental function examination. So level of consciousness, which is accessed by the help of Glasgow Coma score, is very important in this case. So the total score is 9 in this case, that is E3, V1 and M5. And so beside that, we can go for examination of the cranial nerve examination. So in this case, since the patient has a low GCS, so we are unable to perform all the cranial nerve examination. So we can quickly go through like cranial nerve, like oculomotor nerve, with the help of, as we can see, the pupil size in this case, and others like facial nerve, as we can make out from the facial deviation. Okay, then other like vagus nerve or gag reflex can be seen when we do suctioning of the patient in that case. So otherwise, rest of the cranial nerve examination is difficult to examine in such a case with the low Glasgow Coma scale. So on the examination of the motor examination inspection, we should look for the bulkiness of the bilateral upper and lower limb. So as this case was presented acutely, so there was both the bilateral limb were symmetrical, and there was absence of any involuntary movement, and the bulk were normal, and there was no tenderness. The tone was normal in this case. This helps to differentiate between the upper motor neuron lesion and the lower motor neuron lesion. And the power of the patient was, it was 1/5 over right upper limb and lower limb and the right half of the body, whereas in the left side of the body it was 5/5. Power was 5/5. So similarly, talking about the reflexes, so you can look for the deep tendon reflex like tricep, bicep, and supinal reflex, and superficial reflex like plantar, premasteric, and abdominal reflex. So in the case of upper motor neuron lesion, so reflexes are usually exaggerated, and in this case we found exaggerated reflexes in the knee joint, knee reflexes, ankle reflex. Similarly, sensory examination. So since the GCS was not that good in this patient, so it was difficult in accessing the sensory examination of the patient. And posture and gait, so to rule out other causes of cerebral hemorrhage, so we can look for posture, but because the patient was brought by the patient party and was in unconscious state, so we were unable to do this examination as well. So this completes our examination.
Okay. Wait, Prakash. So you
Yes,
have
sir.
done the general examination and the specific CNS examination. Okay. So in different readings, you have done the examination. Now, what are the positive finding in your CNS examination?
Positive findings. So in the high mental function, the patient has low GCS.
Mm.
Number one. So on examination of oculomotor nerve, the bilateral pupil size were equal and reacted to light. So this was not that significant in this case.
Mm.
So there was the power of the right half of the body was only 1/5, which is also.
So there is right-sided hemiparesis. Okay.
Yes, sir. So and the reflexes were exaggerated in this case. So these are the positive findings.
Plus, there is a facial nerve palsy.
Palsy with facial nerve deviation is present.
So what type of facial nerve palsy it is?
So this is a upper motor neuron type of facial nerve palsy.
Okay.
So because
about
patient
this upper and lower motor, okay. So there is a upper motor facial nerve palsy, right-sided hemiparesis.
Yes,
right?
Yes, sir.
And patient is unconscious.
Patient is unconscious, sir.
Now tell me your clinical diagnosis.
So with this examination, with this history and examination, so we can make a diagnosis of, firstly, with this we can make a diagnosis of only stroke. So it can be either hemorrhagic stroke or could be ischemic stroke. So to rule out that, we have to, yes, so stroke.
Then
the other can be.
Remember, your diagnosis should include your site of the lesion, okay?
Yes, sir.
Nature of the lesion and
Yes,
the depth,
sir.
okay, and what is the pathophysiology, okay? So you should include these three things. So where is the site of the lesion?
So site of, since there is right-sided weakness of the body, so site of the lesion is on the left side, so which is the dominant hemisphere. So this is the right-handed person. So left side is left hemisphere.
So there is stroke in the left side, okay? Left side where?
So left side,
left side where?
Left side could be in the deep side, like deep region of the brain, like basal ganglia could be, because the patient is hypertensive at the time of presentation. So could be basal ganglia, could be the cause.
Okay. So you see, usually while localizing the site is very important, okay?
Yes.
So just remember what could be the possible site, okay? So number one, it could be the, where is the motor area of in our brain? It's in the frontal lobe, right?
Frontal, yes.
So start from the frontal lobe, okay? Okay. And in this case, since it's a right side weakness, so it should be in the left side, right?
Yes, sir.
So it should be in the left frontal lobe, that is in the left motor area, okay? Left motor strip, number one, okay? So could it be in the left motor area? Number one. Number two, the motor fiber goes down from the
cortex to the
motor area, the motor cortex to the, where does it go?
thalamus, then
No, it goes to the, this fibers goes to the internal capsule, right?
yeah, yes, sir. Is a capsule first.
Internal capsule. So next sites could be internal capsule and the surrounding area. Okay, like basal ganglia, thalamus, it's all surrounding the internal capsule. Okay, or now this fibers goes to the motor fiber. Okay, I'm talking about motor fiber. These are the corticospinal fiber. They start from the motor cortex, right, in the frontal lobe, and
Yes,
this fiber, these are the descending motor fibers. So they goes from the motor cortex in
motor
the
cortex.
frontal lobe, and these motor fibers descends subcortically into the internal capsule. Then there goes from there in the internal capsule into the, where does it go?
Then it goes into pyramidal tract.
These are the pyramidal tract. Okay, pyramidal tract is the corticospinal
Corticospinal.
fibers. Okay, these are known as the pyramidal fibers. Okay, so these are the corticospinal. You say pyramidal tract or corticospinal tract, it's the same thing. Okay,
Yes, sir.
so just trace these fibers. Okay, so I'm just trying you, helping you to trace these motor fibers. So they start from the motor cortex. Okay,
Yes, sir.
the pyramidal cells, they start from the pyramidal cells in the motor cortex. That's why they are known as pyramidal tract.
Pyramidal tract.
So in the frontal lobe, in the motor cortex. Okay, so this, they descend down this descending corticospinal fiber or pyramidal tract, whatever you say, goes down into the internal capsule. Okay,
Okay.
then from there they goes into the, where?
So now they move into the medulla, brainstem.
Yes, brainstem. Now, so they touch the brainstem in the midbrain, in the
Also,
in the medulla. Okay, then they finally cross in the
cross in the medulla.
medulla. Okay, then they descends further into the spinal cord. Okay, so the name is corticospinal fiber. Okay, so they start from the cortex and they relay into the spinal cord. Okay, into what?
They relay into the spinal cord, then spinal
Where?
nerve through the spinal nerve.
No, into this.
Anterior, in the anterior horn and.
Okay, in the anterior horn cells. Okay, so these are the all. So what I am talking right now is the upper motor fiber. Okay, upper motor neuron. Okay, so start from the cortex, motor cortex, trace this fiber, it goes subcortically into the internal capsule, then to the brainstem, then finally cross. Okay, in the, there is a decussation in the medulla, then
Medulla.
then
In
down
the spinal.
is the, then relay into the spinal cord, into the alpha alpha motor. Okay, alpha neurons. Okay, so up to that, up to the relay, it is the
Upper motor.
upper motor.
Neuron.
From the spinal cord, it starts the lower motor. Okay, so that is the next thing. So where could be the site of lesion? Now it could be in the frontal lobe, in the motor cortex. It could be in the internal capsule. It could be in the brainstem.
Brainstem.
Why not brainstem? Okay, it could be in the brainstem also.
Yes.
But I want to tell you that now you have to differentiate whether it is in the frontal lobe, motor cortex, whether it is in the intercapsule or the surrounding area, or it could be in the brainstem, because all this lesion can lead to hemiparesis. Okay,
Yes. Yes.
but a lesion in the spinal cord cannot cause hemiparesis. Okay, very less likely, rarely. Okay? A lesion in the spinal cord causes either quadriparesis or monoparesis, or maybe paraplasia. Okay, depending on the site of lesion. So localizing the site of lesion is very important. Okay, so you should have a sound knowledge of anatomy. Okay, so you should just revise the, I'm just revising you the knowledge of anatomy. Okay, where could be the possible site of the lesion? Now start from the frontal lobe. Okay,
Yes, sir.
okay, so could this lesion be in the frontal lobe, in the motor cortex?
Yes, yes, sir, yes.
Yes, why not? Because there is right-sided hemiparesis. Okay, number one. Number
Left
two,
sided dominant.
facial deviation, it can occur. Why not?
Yes, sir.
Why there is facial palsy?
Facial nerve.
Okay, there must be same-sided facial lesion. Okay, why there is a same-sided facial lesion?
Because the nucleus of the facial nerve
Hmm.
lies close.
Sorry. Okay, let me again explain you.
Yes.
Facial, again, like we talk about upper motor, lower motor. Okay, facial nerve is. Let's talk about the motor nuclei of the facial nerve. Okay, where is the location of the motor nuclei of the facial nerve?
So motor nuclei in the pons.
Pons, right? So in the pons there is a facial nuclei. Okay.
Yes.
Now this facial nuclei, I'm talking about the motor nuclei. Okay, that should be, again, that should have upper motor control. Okay, so where does this upper control comes from?
The motor comes from the cortex.
Again, cortex. Okay.
Yes.
Now the motor fiber of this facial nerve is known as, do you know?
Upper motor neuron.
This is known as corticobulbar fiber. Okay.
Cortical, yes, sir.
Okay, this is known as corticobulbar fiber. So the supply to the facial motor nuclei comes from, again, from the motor cortex, and this name of the fiber is known as corticobulbar. Okay, from cortex. Bulb is brainstem. Okay, so these nuclei are in the brainstem, so bulbar. So corticobulbar. Okay, so this corticobulbar, they again pass like the corticospinal tract. Okay, from the cortex, they descend down subcortically into the internal capsule and finally into the brainstem. Okay, and they supply the respective nuclei. Okay, so facial motor nuclei has its corticobulbar fiber. Similarly, other like third nerve, fifth nerve, or every cranial motor nuclei has a this corticobulbar fiber. Okay, so they have a respective corticobulbar fiber. So just focus on the facial nerve. So similarly, facial nerve, it has a corticobulbar fiber coming from the motor cortex. From the cortex, it descends down, okay, into the internal capsule and supplies and comes to the midbrain, and it goes to the pons and supply the facial motor nucleus, which is located in pons. Okay.
Yes.
So again, facial motor nucleus has a upper supply and the upper motor neuron. Okay, that this corticobulbar fiber is nothing but a upper motor neuron of facial nerve. Okay.
Yes, sir.
So why there is facial nerve palsy? Because this corticobulbar fiber is affected. Okay, be whether it is in the motor area in the cerebral cortex, or there is a lesion in the internal capsule. There will be a, and with involving the this corticobulbar fiber, there will be a facial nerve palsy, right?
Yes, sir.
There will be a facial nerve palsy. Now again, so there is a right-sided hemiparesis. There is a facial nerve upper motor type of facial nerve palsy. Then the lesion could be in the motor in this cortex. Okay, in the frontal lobe. Okay, why not? Number one. Number two, the lesion could be in the internal capsule and the surrounding area. Okay,
Yes, sir.
why? Because again, internal capsule has a descending motor fiber, the corticospinal fiber, plus
Yes,
it has corticobulbar fiber to the facial nerve also. Okay, so the lesion can be in the internal capsule or the surrounding area. Okay, like you see, there is a massive hemorrhage around the basal ganglia or the thalamic area. Okay, and it is near to the internal capsule. It will cause compression of the internal capsule, and it will cause hemiparesis and the facial nerve palsy. Okay,
sir.
now can the lesion be in the brainstem?
So yes, with this, yes, it can be in the brainstem.
Brainstem.
Yes, sir, because the fibers pass through it, so can be in the
But
brainstem.
remember, okay, in brainstem,
There is
besides the spinal tract, the descending fiber, motor fiber, there are a lot of things in the, because brainstem is a very small area, okay, and there are various things in various things that are near to each other, okay, like
yes,
there's a lot of
center,
huh?
lots of nuclei
There are
and
a lot of motor nuclei, there are a lot of cranial nerve nuclei in the brainstem,
brainstem.
okay. So imagine there is there is a lesion in the brainstem with only facial nerve palsy, okay. This is not
Yes,
very common, okay. Had it been in the
yes.
brainstem, not only facial nerve involved, okay, there would have been
Others
nerve
cranial nerve.
involvement also, right?
Yes, yes.
Let's say in pons, besides facial nerve, what are other cranial nerves in the pons?
Others are vestibular cochlear,
Okay, what else in the face pons?
trigeminal nerve,
What else? Very
trigeminal,
important cranial nerves related to seven nerve.
trigeminal, abducent, facial nerve, and
Abducens, yeah, abducens is very closely related to the facial nerve.
facial nerve.
So had it been lesion in the pons, abducens nerve is 99% involved, okay, if it is in the pons, because they are very closely related.
Yes. It
Okay,
is
in this
around
case, there is no facial nerve, there is no involvement of the sixth nerve, okay. Sixth nerve is supplies the,
lateral rectus.
yes, so there is no lateral rectus palsy, okay, and it is very easy to check the lateral rectus palsy, okay, even in the unconscious patient.
Yes,
So once the brainstem is less likely, okay. Do you understand what I'm talking about?
yes, yes.
So simply hemiparesis doesn't mean that the lesion could be in the brainstem, okay, because brainstem is a very dense area, okay. There are a lot of cranial nerves involved, so the involvement of only facial nerve is very rare, okay, in case of lesion, because there are a lot of cranial nerves. So let's say pons, then there would have been involvement of trigeminal nerve, there would have been involvement of the
Abducent nerve.
abducens nerve, okay. So this is how you should think, okay. So could this be lesion in the spinal cord?
This is this likely in the spinal cord.
It's impossible, okay, not less likely, it's impossible, okay.
Yes.
So now you come down to just frontal lobe and the frontal lobe motor cortex and the internal capsule, okay. These are the possible site, okay. So this is how you should localize the site of lesion in any neurological cases, okay.
Yes.
Okay, then so where is the site of lesion now?
Site of lesion could be around in the
Okay,
cortex.
be specific, okay.
Yes, so it could be around the motor cortex, near the internal capsule.
Left-sided motor cortex,
Motor cortex.
number one. Number two,
So in the inner capsule.
left-sided internal capsule and surrounding area like basal ganglia, okay, or thalamus, okay. Yeah, the two possibility, okay.
Okay, sir.
Okay. What else you want to add?
In this case, brainstem is
In
best.
diagnosis, you should say one is site of the lesion, okay. So the lesion is where either, so you have a two differential diagnosis. One is sorry, by if you just focus on the site, okay, either the lesion could be in the left motor cortex, number one, or it could be in the left internal capsule and the surrounding area, okay. These are the two possible
These are the
sites,
two.
okay, site. Now what is the nature of the lesion? It's a vascular lesion, okay.
Vascular lesion.
And nature, just I want to focus on, there are different nature of lesion, okay. It could be congenital, it could be acquired, okay. This is not a congenital lesion. In acquired also it could be inflammatory lesion, it could be infective lesion, it could be degenerative lesion, okay. It could be neoplastic lesion, it could be vascular lesion, okay, like this one, okay, stroke. So this is a vascular lesion, okay, this is a stroke, okay. So nature of the lesion is vascular, okay. So it's a vascular lesion involving either left. Why it's a vascular lesion? Because it's sudden onset. Okay, any sudden onset is sudden onset of deficit. Okay, in the patient, you should consider a vascular lesion. Okay, like a stroke. So it's a vascular lesion involving either motor cortex or internal capsule of the left side. Okay. Now, what is the deficit in this patient?
Deficit,
Yeah.
weakness of the right half of the body.
Okay. So
Also,
that is left-sided, sorry, right-sided hemiparesis. Okay. So it's a right-sided hemiparesis. Why not? Right?
yes, sir.
You can say right-sided hemiparesis with upper motor type of palsy. Okay. So in your diagnosis, you can say now right-sided hemiparesis with upper motor neuron type of facial palsy due to vascular lesion involving either left-sided motor cortex or left-sided internal capsule. Okay, this should be your complete diagnosis. Okay.
Yes, sir.
Clinically, you have diagnosed. Okay, from history and examination, right? Any doubt?
No doubt.
Again, I want to repeat. The diagnosis would be now right-sided hemiparesis with facial palsy. Okay, the facial palsy also upper motor neuron type. So right-sided weakness, right-sided hemiparesis with facial nerve palsy due to vascular lesion involving involving left-sided motor cortex or left-sided internal capsule. Okay, now you are confused about these two lesions, whether it is left-sided internal capsule or left-sided motor cortex. Okay. So this is your clinical diagnosis, right?
Yes.
Now what to do?
So now next line is, so we should make
Now how to make diagnosis? Okay, now confirmatory diagnosis. How you will confirm the diagnosis? Now clinically you have made the diagnosis like this. Okay, it's good. Now what further? Now how will you confirm your diagnosis?
So now to confirm the diagnosis, we'll say investigation. Like the first one is investigation of choices, plain CT head or CT head. CT scan.
Okay. Plain CT scan brain. Okay. Why
scan.
not MRI?
So MRI is time consuming and it is very it does not.
An MRI can be done in this case.
Can be done, but because the early MS is difficult to diagnose and it is time consuming in the patient, so we have to buy time in case of stroke. So CT scan is fast and reliable. So CT scan is the investigation of choice.
Yes. So just do plain CT scan. Okay. MRI, it's time consuming. You are right. You are wasting your 1 hour. Okay, in doing MRI. CT scan just takes a few minutes. Okay, 2 minutes, 3 minutes, and you will have your diagnosis. Okay, and plus just to know the whether initially you have to just now from history you are almost sure it's a stroke. Now you are just differentiating whether it is ischemic or hemorrhagic. Okay, and again scan is very helpful in this. Okay, MRI is little bit confusing to know whether it is blood or okay it's ischemia or blood. Okay, or hemorrhage. CT scan very simple. Just you see the white blood. Okay, just go ahead with the plain CT scan. It will save your time. Okay.
So also MRI does show blood well within the first few hours of presentation, so it is less helpful in the diagnosis as well.
Okay, just you have to differentiate first whether it is ischemic or hemorrhage. So for that, go for CT scan, plain.
Blood. with the mass effect, you can see the mass effect. There is a midline shift slide, midline shift towards the right side because of the.
Yes, you can use the cursor. Okay, you don't need a pointer anything like this. The cursor is देखो ना सर मजाले. By the first one.
But I'm trying on that. Sorry for the delay.
Anyway, explain. I think explain got it.
So you can see in the first picture. So there is a hyperdense white lesion. You can make out the white lesion is present. So this is a hyperdense lesion. This is likely blood in the case of CT scan, and you can see there is a
means white, right? Just explain like
yes.
that.
So blood means white in the. So blood is seen white in the case of CT scan. And with the so also the bone is seen white, but with the help of Hounsfield unit, you can make the difference between blood and the bone. So in this case, you can see the hyperdense lesion with the mass effect that is pushing the brain towards the right. So there is a hyperdense lesion with the mass effect. So this is likely blood, as the patient has hemiparesis and he is hypertensive. So this is likely hypertensive bleed in the basal ganglia region.
Okay, you can see the use, Prakash,
so I think can you see the pointer? Can you see the pointer now?
Oh, wow. Printer. Oh, okay. Marker, I can see. Okay.
Yes. So I think you can see the pointer. So you can make out this is the hypertense lesion. So this is
where is the site? Where it is? Right side, left side?
This is left-sided. So this is left-sided hyperdense lesion. So this is likely outside the internal capsule. So this site could be.
Can you show where is the area of in the right side? You can see the basal ganglia and the internal capsule. Okay, just
yes. There is a
hyperdense. The normal side.
So okay, so this is the right side. This is the normal side. As you can see, there is a little of hyperdense region here. So it's like a arrow. As you know, the inner capsule has the anterior limb, genu, and the posterior limb. So you can make out this as a inner capsule. So outside this area is the basal ganglia, globus pallidus, and the putamen. So I hope you are clear.
Where is the thalamus?
So thalamus lies more close to the ventricle, third ventricle. So this area, the area medial to the internal capsule is the thalamus. Here you can see this is the thalamus. And this is the frontal horn of the ventricle, lateral ventricle. And the side, there's a hyperdense area here. This is the caudate nucleus. So it is quite difficult to make out because of the mass effect. So this is the caudate nucleus lies over here, and the area just lateral to the third ventricle is the thalamus. So and outside the internal capsule is the basal ganglia region.
Okay, so there is a huge hematoma, okay, involving the left side. including internal capsule and this basal ganglia area. Okay.
Yes, sir.
The left
So
side.
yes, with the mass effect.
Yes.
As you can
And
see, the ventricles are pushed.
yeah. So there is used blood. The blood, I don't know, maximum it's more than 100 ml. Okay, in the left
Yes.
side. And next thing you see, you compare the right frontal horn and the left frontal horn. It is left side. It is effaced. Okay, because of this used hematoma, it is compressing the left frontal horn, and there is slightly there is a mass effect with side there is a shift. Okay.
Yes.
Okay. Now what to do?
So now next is so looking at the GCS. So we have to
What is
decide.
the GCS of the patient now?
Now, I mean after surgery or before surgery?
No, no, no. What was the GCS of the patient
GCS was
at presentation?
E3. Eye to call was there, and B1. Patient was unable to speak because of the left-sided dominant hemisphere, and he could localize. That is M was 5. Method was 5. So his total GCS was 9/15.
So such a patient, okay, with right-sided weakness, with facial palsy, okay, sudden onset, with at an unconscious state, okay, and you do a CT scan, and CT scan shows a huge hemorrhage, okay. What to do now?
So first of all, we have to control initial management is always so ABC should be checked, and if we need to integrate, so at any criteria.
Prakash, can you tell? Can you be quite louder? Okay.
Okay, sir. Okay. So first of all, the initial management should be focused on the airway, breathing, and circulation. And since this patient presented with a history of hypertension, so his blood pressure should be immediately controlled in the emergency department. So that would help. That would help to minimize the uh, bleeding. So am I audible now? Can you hear me?
Just raise your voice more. Be louder.
Yes, sir. Yes. Okay. So can you hear me?
Yeah.
Okay. So initial management. So after ABC, so yeah, we should always secure the airway of the patient because the GCS is quite low. That's 9/15. So
Did you
other
intubate the patient?
intubates. So there's no indication as we usually intubate the patient when the GCS is less than or equal to 8. So since the patient had GCS of 9,
Okay.
so we waited before surgery. And the next thing is we have to control the blood pressure immediately because this helps to reduce the risk of expansion of the hematoma.
Okay.
I think so. So this is important initially. Then we also have to decrease the increase ICP, so we can give mannitol, like drugs like mannitol, which helps to lower the ICP. Then the role of anti-epileptic drug like levetiracetam is also there, so we can give levetiracetam as a prophylaxis to epilepsy, seizure disorder.
Okay. You give antiepileptic to reduce the risk of seizure. Okay.
Yes, sir.
Then.
So since the volume of the blood, since the volume of the blood is quite large and there is mass effect and the tissues of the patient is low, so indication there is an indication for surgery. So we have to proceed for surgery evacuation of hematoma with decompression craniotomy and lax duroplasty.
Okay, this patient ultimately needed surgery. Okay,
Yes, sir.
and surgery was done in this case. Okay, so your
Yes,
aim is to remove the hematoma as much as possible. Okay,
yes, yes,
so craniotomy and evacuate the hematoma. Okay, that's simple.
yes.
Okay, now what is the now postoperatively? What is the condition of the patient?
So now, post-operatively, the patient, yeah, so he has eye opening or spontaneous eye opening. So he speaks, so we can only hear incomprehensible sound. So his verbal response is two only because the left side of the hemisphere is involved and the dominant hemisphere is involved. So he has only verbal response of two, and motor he can still localize the pain. So he's still unable to obey the command. So that is the GCS at present. E4, V2, M5.
Okay, so if you see such a CT scan, okay, with left-sided hemorrhage, this is a big hemorrhage. Okay,
Yes, sir.
it has been operated. Still, verbal is
Two.
right.
So because our speech, so since the patient is right-handed person, so left-sided, left hemisphere is dominant in this case. So because of the involvement of the left hemisphere, which is dominant, so patient is still unable to have speech. Left dominant because of the involvement of the dominant hemisphere.
Okay. So since left-sided is involved, okay, usually left-sided lesion causes aphasia. Okay, that's what
Yes.
I want to emphasize. Okay, so left-sided lesion usually first type of lesion because where is the speech area? Speech area is in the left side. Okay,
Yes.
motor speech area in the frontal lobe. Okay, sensory speech area in the frontal and the temporal lobe. Okay,
Yes.
whenever there is a massive lesion in the left sided, usually speech area is involved. That's why there is a always chance of having aphasia. So this patient is having aphasia. Okay,
Yes.
so that also you can tell in the diagnosis. Okay, because this patient has aphasia.
Yes.
Okay. Now just summarize and conclude the your presentation. Okay.
So this 45 years old gentleman, so we initially presented to the emergency department with the history of weakness of the right half of the body, and was found in unconscious state, was unable to speak with facial nerve deviation, and with low GCS, and who consume alcohol on a daily basis. Uh, so uh, so we did investigation, and was CT scan was done, which showed hematoma in the left basal ganglia. And we operated the case. So now the patient is doing well. And so in case of, so we also should know whether to operate or not in the case of this intracerebral bleed, as we should also think about other bleeding site, as basal ganglia is the most common site of hypertensive bleed. So beside that, thalamus can be the other site, cerebellum can be the other site, like as Sir said, internal capsule could be the site. So I think so with the help of history. So initially, with the help of history and examination, initially you should be able to know at least make out some differential diagnosis like cerebral vascular accident initially. So to confirm the diagnosis, you have to perform the investigation like CT scan, so that you can because the management lies on it, whether it is ischemic or hemorrhagic stroke, then you can follow accordingly. If it is hemorrhage and if the patient requires surgery, you have to operate. Otherwise, if the scenario is ischemia, then you have to follow accordingly. So I think that helps you to diagnose the case, and help in the management.
Prakash, open up your video. तिम्रो video खै त? Video हाल. Okay. Now, okay, all the stroke, you know, whether in the case of, we are today discussing about hemorrhagic stroke. Sometimes you can see such a larger stroke, you know, with high volume hemorrhage, or sometimes very small hemorrhage. Okay, so small hemorrhage, you don't need to operate, just have to control the blood pressure. Okay, so your line of management includes number one, control of blood pressure. Okay,
Control of blood pressure.
Control. Okay, so you should see, monitor the blood pressure, initially, plus in the future also we keep on giving antihypertensive. Okay, so you should control the blood pressure, because sometimes we have seen small hemorrhage that can be converted into a larger hemorrhage. Okay, so you have to control the blood pressure optimally. Okay, number one. Number two, if the patient has a features of raised ICP, then you should control you should manage the ICP. Okay, either medically, okay, or if not possible, like in this case, you go surgically. Okay, you have to control the intracranial pressure. Number two.
Yes, sir.
Now, once the patient survives the attack, then the next level of management is now, what is the most important next level of management now, after the patient is during the postoperative period?
So we have to prevent the patient from post-operative complications like pneumonia. So that is very important, to prevent the patient from post-operative complications like pneumonia. So because usually because of the low GCS, patient will be unable to remove the sputum from the chest, so they can develop pneumonia. So we have to give chest physiotherapy, and also the patient should be mobilized, and we also should prevent the bed sore, like bed sores, which can be complication from long-term bedridden patient.
Yeah. So usually if the patient is still unconscious after operation, okay, or maybe sometimes we are doing conservatively, patient is unconscious, patient may be in the ventilator, you have to take care of chest, okay, prevent pneumonia. That is one part. Next is, if the patient has a hemiplegia, hemiparesis, okay, there is a weakness, then
physiotherapy,
okay, mobilization, whatever is needed. Otherwise, so to avoid that, you have to do continuous physiotherapy and
chest physiotherapy and limb physiotherapy.
Another aspect of management. Okay, so not only the medical, not only the surgery, physiotherapy rehabilitation is also a part of the management of stroke.
Yes.
Okay.
Yes, sir.
What else?
So also we should continue giving antihypertensive to the patient. Antihypertensive drugs should be continued in the post-operative
during
period.
discharge. Yeah, you should counsel the patient regarding the future. Okay, future incidents of stroke. Okay, once a patient has a stroke, he has a chance of having next stroke also. Okay, you should counsel the patient, let him adhere to his medications. Okay, usually if he is on antihypertensive,
so that should be continued.
About that medication. Okay, regular follow-up, regular checkup. Okay, so compliance to the medicine is also very important. Okay, especially this antihypertensive. Okay, and the risk factor. Okay, any risk factor that is modifiable, that should be modified. Okay, anything else, Prakash?
Yes, sir.
I think that concludes the presentation. Okay, now you take the questions from the audience participants. Okay.
Yes, sir. Yes. So I think with this history and examination and these investigations, so I think everyone will be able to now diagnose the case. Diagnose the case in the department. with this history, and they can send investigation, and they can management. They can manage the patient in the emergency department accordingly, like decreasing the blood pressure, decreasing the ICP. So I think so this conclude our session. So anybody has any question, we can ask. So if you have any confusion or queries regarding this case discussion, you can always, you're free to ask questions.
Thank you, sir. And thank you, Prakastai. It was a very fruitful session. Now we would like to move to question and answer discussion session. I request our technical team, Ashok Pandey Dai, Omnath Bhattrai, Sudeep Sharma, Achal Verma, to mediate for question and answer discussion session.
So EVD. So EVD stands for external ventricular drain. So can I explain, or?
Yeah, go ahead.
Okay. So external ventricular drain is, so it is one of the procedures to release the ICP. So this can be done when there is presence of intraventricular extension of the hemorrhage. That is, the basic ganglia bleed can be extended towards the ventricle, or thalamic bleed can be extended to the ventricle, and that can raise the ICP, causing hydrocephalus. That can cause the obstructive hydrocephalus to the patient, and thus decreasing the GCS further. So in that case, we can also do external ventricular drainage in that case. So is that okay?
Yeah, Prakash, you are right.
Yes, sir.
So EVD is one of the measures to reduce the ICP. Okay.
Yes, sir.
So usually in hemorrhage, as you have said, this causes obstructive hydrocephalus, because when there is blood in the CSF, it will cause obstruction and it will cause obstructive hydrocephalus, and the ICP will be raised. Okay. So to reduce that ICP, you have to put external ventricular drain in case of hemorrhagic stroke. Okay. And external ventricular drain has other uses also. Okay, it may be like not only in stroke, like let's say in traumatic brain injury. Okay, in severe head injuries, there will be raised ICP. So you put the catheter in the ventricles. Okay, external ventricular drain is nothing but putting a catheter in the ventricle. Okay, in the ventricle. So there are two benefits from it. Number one, you can directly drain the CSF from these ventricles, so that when you drain the CSF, ICP will be reduced, number one. Number two, if you put a catheter in the ventricle, then you can measure the ICP also, okay, intracranial pressure also. So yes, second benefit is measurement of the intracranial pressure. These are the two benefits of external ventricular drain. See other questions also.
Yes, thank you.
Sir, next question is how to measure the volume of bleed.
Yes, Prakash,
so
how to measure
the volume of blood. Okay, so as you can see in this CT scan, so you have to find the maximum blood dimensions present
Prakash,
in this.
Share your presentation. Okay, you can show the CT scan.
Okay, yes, I'm doing that. So, so I think now you can see the CT scan. So to measure the volume, so firstly you should identify the maximum volume of the blood. So looking at this CT scan, so you can see the lesion right from here. So here, this is the first slice, you can see the blood. This is second. So assuming, so this section has the maximum blood volume. So you should first measure this anterior posterior. So from this end to this end. So this should be measured first. So for the measurement of this, so you are given here, you can see in a small, so there is a lining here. So this usually CT scan are of 5 mm slices. So this gives you the measurement. So taking this as a scale, you can measure. So you can bring you can bring this scale here. So and you can measure this diameter first. So length first. Okay. So after that, so this diameter should be from this top to this top. Then again from this side to this side. Again you have to measure here. Again the scale is given, and so again. So the length from this side to this side should be calculated. Okay, so these are the two. Then for the height, so for the depth or height of the lesion, so you have to count this number of slices where the lesion can be set. So in this case, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, so there are number of 12 slices are there where you can see the lesion. So initially the measure like this length, this breadth, and the height. So this divide by 2. So we'll give you the estimation of the blood volume. So I think, so am I right, or you want to add something?
So and the measurements should be in the centimeter. Okay. So it's
centimeter, yes.
Cube. Volume is centimeter cube. So length, breadth, height means the depth. Okay, from starting from the lesion where it start to the end point. Okay.
End point.
The gap is usually, slices are taken sometimes in the 5 mm, sometimes in the 1 centimeter. Okay, depends upon the different institution. Okay, so usually they are 5 mm. So if it is 5 mm, then times whatever slices. Okay.
Yes.
And it should be in the centimeter. Okay.
Yes.
So length is in the centimeter, breadth is in the centimeter,
and height centimeter.
That should be divided by the 2. It's a nothing but a formula of a ellipsoid. Okay.
Yes, sir, ellipse.
Go for next question.
So next question.
I think that is clear. Okay.
I hope everyone is clear. So there is a question. Will only a sudden onset give a diagnosis of vascular lesion? So usually, as Sir has explained, so vascular lesions are usually acute in onset. So you should first think, so if the patient presented to the emergency department with acute onset of such focal deficit, so you should think about vascular lesions.
Yes.
Rather than thinking others.
In vascular lesion, you can think of various lesions, okay? Like not only stroke, okay?
Stroke, yes, sir. It so could be arteriovenous.
Yeah, malformation,
aneurysm, very aneurysm. I think that is clear.
We go to the next question.
Next question. So indications for surgery. So when to operate or when not to operate. So is one of the questions. So when so we can also go for non-surgical management, as we do not operate all the patients with vesicular bleed or hemorrhagic stroke. We do not operate all the patients. So non-surgical management can be done. So in case of when there is minimally symptomatic lesions, like the patient is alert and the patient has only mild hemiparesis and the GCS is good, so we can wait and watch and just control the blood pressure. So I think in that case we can go for conservative management. Am I right, sir? Or you want?
Yeah.
So beside that, we do not operate the patients who have high ICH score. So ICH score is intracranial hemorrhage scoring system. So there's a system ICH score. So if the patient has high ICH score, that doesn't help the patient outcome. So in that case also, we do not usually operate. And if there is signs of brain death, so signs of brain death, and there is poor neurological patient, the patient is comatose, and there's large hematoma in the left or the dominant hemisphere. In that case also, we usually do not operate the patient. So because that is not going to help the patient
sometimes
in the outcome.
You are right, Prakash. Sometimes, yes, there are a few patients who comes in such a critical condition, like, like almost like a brain death, okay? So they have GCS 4, GCS 3 with no brainstem reflex, pupil dilated and fixed, a big hemorrhage. Surgery won't help, okay? So in that say, we have to be sorry, okay? So we can say, You should not operate in
There's-
this case.
Yes.
And rest of the indication, okay, usually the hemorrhage, most of the hemorrhage, they are very small, okay, with hemiparesis, patient is conscious, oriented, you don't have to do nothing, okay.
Yes. You
Just
can observe them.
conservative management, control the blood pressure, do physiotherapy, and discharge the patient. But some hemorrhage with larger volume, okay, let's say more than 30 ml, with features of raised ICP, okay, then in those cases, you have to go for operation, okay. There are simple few
Yes.
indications for surgery. And you should know
Yes,
when not
yes.
to do surgery also.
Yes, sir.
Okay.
This is
next.
very important. When not to operate. So next question is, so they have asked, tranexamic acid is initiated early, or borehole drainage is first indicated in the management of hemorrhage. So I think borehole doesn't help in the case of cerebral intracerebral hemorrhage. So this is of no use in this case, because borehole is used only in case of subdural chronic subdural hematoma. And the role of tranexamic acid is, as there has been trials like crash trials. So the trials has shown that the role of tranexamic acid, if the patient has presented within first 3 hours of the accident, so I think that can that has some role. So beside that, there is no role of tranexamic acid. So the primary should be blood pressure should be controlled. So I think, sorry, we'll add something more.
Yeah, you are right.
Yeah.
So usually tranexamic acid has been studied a lot, okay. Usually in the traumatic brain injury also it has been studied a lot, the crash trial. So it has some role if you present early, and even in hemorrhagic stroke also, if tranexamic acid is given earlier, okay, it will prevent the expansion of hematoma, okay, expansion of hematoma, because initially there will be small hematoma, then later on, if the blood pressure is not controlled, okay, due to some pathophysiology, okay, this hematoma will expand. That expansion can be reduced by tranexamic acid, okay. Some studies have shown it controls significantly, okay. So tranexamic acid can be given, okay.
Yes. Thank you, sir.
Regarding
So
a
the
borehole,
next,
there is nowadays, usually in hemorrhage, you do a craniotomy and evacuation of hematoma, okay. Borehole is not, you can say mini craniotomy can be done, okay, small craniotomy, okay. And borehole sometimes can be done if you are sure of, the main localizing the hemorrhage is the main thing. So borehole with some, let's say nowadays, endoscopy has been used for drainage of the hemorrhage, okay. So yes, you are right, borehole can be done in some cases where endoscopic facilities available, okay. So you don't have to do a big craniotomy, do a small borehole, do endoscopy, and by endoscopy you can remove the hematoma, okay. It's minimally invasive surgery, okay.
okay, sir. Thank you, sir. So next question is, so one of the students have asked, how do we differentiate between ischemic and hemorrhagic stroke clinically? So as we have already discussed that clinically you can only localize the lesion. So because from the history we can
I think,
localize
yeah,
the lesion.
this
So
question is relevant, okay, and
yes,
can diagnose, okay. Now, one thing is clinically, you see how many cases you have seen with ischemia, okay, how many cases you have seen in ischemic stroke with loss of consciousness? Very few.
very
Okay.
yes,
Because in ischemic cases, patient doesn't lose consciousness initially, okay. Why? Because if it is a very small stroke, okay, very small ischemic stroke, patient does not lose consciousness. But patient has a massive stroke, massive ischemia, okay, let's say MCA, middle cerebral artery stroke, then, and the stroke is in evolution, then patient will ultimately lose consciousness. But usually we have seen that in ischemia, patient will have normal conscious level. But in hemorrhage also, not in all hemorrhage, like in this case, if the hemorrhage is big,
small,
okay, the volume is high, then patient will lose consciousness. Small hemorrhage, again, patient does not lose consciousness. So you can exactly cannot differentiate the whether it is ischemic or hemorrhagic clinically, but if the patient has a sudden onset of weakness with sudden loss of consciousness at the same time, then you can say it is a hemorrhagic stroke, okay. So you can think like that, okay. So hemorrhagic stroke usually present with sudden onset of weakness and loss of consciousness at the same time.
Same time.
Okay.
Okay, sir.
So usually schema, it is not a usual presentation. Okay, you can say a
User project.
patient as a loss of consciousness and the neurological deficit at the same time. You can say it is a hemorrhagic stroke clinically. Okay,
Yes,
I think
yes.
that can only be said.
Okay, sir. Thank you, sir. So next question is, will aphasia resolve or be forever?
What do you think?
So I think aphasia, so since the left dominant hemisphere is involved, so it is a very gradual process. So we cannot definitely say the patient will regain the speech. So in my, I
In
think,
any patient whose aphasia has been recovered?
so I have, so far I have not seen, sir.
It's not a hard and fast rule. Usually you say that, see any CNS lesion, once the neuron is damaged, it will not
Neural
recover.
damage, sir.
That's the rule. Okay, but
Yes, yes.
our clinical practice, we have seen there are a lot of patients with aphasia. Okay, with a constant this speech therapy, with constant effort, we have seen that patient has recovered slowly, not in
Yes.
days, maybe in years. Okay, they have
Years,
recovered.
yes.
Okay, so you can just think like there is something called neuroplasticity. Okay, brain can regenerate. Nowadays, a lot of research has been done about the neuroplasticity. Okay, so usually aphasia is recovered in children. Okay, usually in the children and the young age, it has been seen, it has been recovered. Okay, so it's not a hard and fast rule that aphasia won't recover. Maybe few person will recover. Okay,
You're right. You're right.
okay,
Yes, sir.
maybe 10-15% they recover. Okay, and we have seen those cases. Okay, after a long period, maybe years of constant this rehabilitation, speech rehabilitation have improved. Okay, so this is a positive note. Okay, next, go to the next question.
Okay, sir. Thank you, sir. So next question is, so what are the ways to prevent hemorrhagic stroke and how to identify risk group?
Now, before that, what about other medication like diabetes? Is it to be continued?
What about other medication like diabetes is to be continued? So I think diabetes sugar levels should always be controlled, so it should be continued in the case of diabetes.
Yes, there is no reason for
Medication
stopping
has-
diabetic
No,
medication. Okay?
yes.
It's also one of the risk factor, so that has to be controlled. Okay, that should be continued. Okay, go to next question.
So what are the ways to prevent hemorrhagic stroke and how to identify risk group?
Yes, this is excellent question. Okay, answer it.
So usually we cannot prevent. We can prevent. Actually, it is not there. There's no hard and fast rule to prevent hemorrhagic stroke. So, but we can identify the risk factor like the age. So age is a risk factor. Okay. So as the patient ages, the arterial wall can be thin out, and so there can be hemorrhagic stroke. Number one. So number second is the risk group are like the patient consuming alcohol, in a chronic manner, and the patient was smoker, and the patient who is a non-case of hypertension. These all are the identified risk factor for hypertensive bleed. So identifying these groups. So I think cutting off the alcohol intake, cutting off the smoking, and exercising will all help to prevent. But so I think that is what I can explain. So next, so
Yes, you are right. So,
yes.
like you should answer this way. Okay, so there are modifiable risk factor. There are non-modifiable risk factor. Non-modifiable, you can do anything. Okay, but modifiable risk factors you can modify. Okay, so you should know what are the risk factors, modifiable risk factor for the stroke. Like you have said, hypertension, smoker.
Hypertension, smoking,
So these are all
obesity.
Okay,
Yes.
hyperlipidemia. These are all the risk. Whatever the risk factor for the atherosclerosis, these are the risk factor for stroke. Okay. Okay. Stroke is also known as what? Brain attack. Okay. Like heart attack,
Yes.
brain attack. So these are all the risk factors for the stroke. So you should identify that, and whatever are the modifiable risk factors that should be prevented. Okay. And there are okay, and there are medications, there are modification of the dietary factors, okay, exercises, whatever the options are available, that should be done to modify this risk factor. Okay, this is how you should identify the risk factors and modify it to prevent the stroke. Okay, so not only hypertension. Okay, hypertension is the #1 risk factor for hemorrhagic stroke, but not only hypertension. We have seen nowadays, okay, this binge alcohol consumption. Okay, and you have seen a lot of young patients, they are having stroke. Okay, a lot of 30 years, 40 years. Okay, this group of patient now is having stroke. Okay, so and once they have this stroke and they have this hemiparesis, hemiplegia, okay, they are handicapped. So there's a very lot of demerits to this. Okay, so just awareness, okay, campaign awareness and about the risk factors, okay, education, okay, counseling of medications, adherence to the medications, okay, compliance to the medications. So these are the important things you should do to prevent the stroke. Okay.
Yes. So the next question is management for ischemic stroke.
Yes.
So for the ischemic stroke, so firstly we should identify again why there is ischemic stroke. So it can be because of atherosclerosis. So it can be because of thrombosis. So cause of ischemia should be identified, and accordingly, so antiplatelet drugs should be started, like aspirin is started. So in the case of ischemic stroke, and patients should be given like atorvastatin, statin drugs should be given. So I think that will help in the management of stroke. And the other thing is supportive care and oxygen supplementation are all required in case of ischemia. So I think that is how we can manage ischemic stroke.
Okay. So I have earlier told you, stroke is nothing but a brain attack. Okay. Like heart attack, brain attack. Yes. Nowadays, the concept has changed for this is management of ischemic stroke. Okay. Drastically, it has been changed. And the management has also been changed. Okay. And we have a very latest management strategy, management policy for ischemic stroke, like we do for heart attack. Okay. So basically ischemic stroke refers to the brain attack. Okay. So earlier management should be there, okay, to prevent the complication of stroke. Okay. So what are the earlier management? The drugs we are talking about, okay, aspirin, anticoagulants like clopidogrel, that's okay. But nowadays, okay, there are more newer dimension to the management ischemic stroke. Okay. #1, okay, now the role of the antithrombolytics. Okay, role of antithrombolytics like TPA. Okay, so if the patient present earlier, now there are different centers in Nepal where they give intravenous TPA. Okay, and that has been practiced. Like you manage the heart attack, okay, you give thrombolytics. Similarly, for ischemic stroke also you give TPA, intravenous TPA. Now that is available in almost all the centers in most of the centers, okay, in Nepal. #1. #2 is the endovascular approach. Okay, now there are a few centers in Kathmandu. Okay, they are doing thrombolytics. Okay, they are endoscopically removing the thrombosis from the different area. Okay, so why ischemic stroke occurs? Either it's a thrombosis or embolus. Okay, so embolus, they get lost in the small vessels like the distal vessel, or maybe in the middle cerebral artery. Okay, or maybe in the thrombosis in the carotid. Okay, so they are doing endovascular removal of this thrombus, and that also should be done as early as possible. So one is intravenous TPA, and next is the endovascular thrombolysis. Okay, thrombectomy. These are two new dimensions that are added to the management of the ischemic stroke. Okay, besides aspirin, clopidogrel, that were the conventional management of ischemic stroke. Okay. So any more questions?
Thank you, sir. Any more questions? I think that's all.
Thank you, sir, and thank you, Dai, for this wonderful question answer discussion session. Now I want to request Ayusha Bhandari to present token of love to our mentor Ayusha? I want to request our mentor for today's program, Dr. Rajkumar Keshi sir, to add few words about today's program.
Okay, thank you very much for this opportunity, especially this your Gray Medicos. Okay, there was it's your wonderful initiation. So this academic discussions like this should be continued. Okay, and we are always there to help. And this sort of discussions should be continued in the future also. Okay, I think we have tried to explain as much as possible. We took a simple case and we described the different aspects and dimension of medicine, how to take a history, how to localize the site of lesion. Okay, so different clinical aspects were they were covered as much as possible with time frame, the time limit we have there. So yes, it was we find it wonderful. Okay, and then this should be continued. Okay, and best of luck to this Gray Medicos. Okay, in the future, please continue with this academic sessions like this in the future. Okay, all the best.
Thank you, sir. I want to request Ayusha Bhandari to present token of love to our presenter, Dr. Prakash Regmidai. I request Dr. Prakash Regmidai to add few words about today's program.
Okay, thank you, the Gray Medicos and all my juniors for giving me this opportunity to discuss this case with our respected Dr. Rajkumar Keshi sir. So this is a very good way of learning. So you can all gain. So I hope you have gained some knowledge, and I hope you will be able to now diagnose and case after looking at such a case. So this kind of program is very nice and fruitful to all of us, including me, including our respected sir and all of you, because this helps us also to get involved in this kind of program and enhance ourselves and share our knowledge. So whatever we know, so we have given to you. So I think this has helped you a lot. So I hope to be with you again in the very near future, and it is a very nice and very good program. So thank you for giving me this opportunity to be with all of you. So thank you.
Thank you, Dr. Prakash Regmidai. Now, finally, I want to call Mr. Ravi Basyal for his Thanksgiving.
Good morning, sir. Good morning, Dai. Good morning, everyone. Today we learn how to approach ischemic stroke and hemorrhagic stroke. So we also learned about canal of examination. We as a student are in stage of knowing something and knowing nothing. Today we learn a lot of things. Firstly, I would like to thank Dr. Rajkumar Keshi sir for supporting and motivating us. And also I also like to thank Dr. Prakash Regmidai for helping us through this wonderful discussion. We hope respected sir and Dai will guide us in upcoming days. With this, I like to thank everyone. I think with this, I want to end my word to Sushil Dakal. Thank you.
Thank you, Ravi, for your Thanksgiving speech. Now we are at the end of the session and we are closing the program. Thank you. I would like to give my sincere thanks again to our respected sir, Dr. Rajkumar Keshi sir, and our respected Dai, Dr. Prakash Regmidai. Thank you for being there. Thank you. Thank you so much.